Coś mi wcześniej chodziło w ostatnim etapie, sięgałem etos jako taki materiał, gdzie jak już nie mam pomysłu co zrobić, to wkładam etos i to samo się zrobi.
Regeneration. Etos jest bardzo przyjazny zarówno dla pacjentów, jak i dla lekarzy, którzy go używają.
Żadnych dodatkowych membran, dodatkowych akcesoriów typu piny czy śruby, przez co to leczenie jest znacznie prostsze.
Uważam, że etos to materiał do zadań specjalnych, bardzo go za to lubię.
Jest łatwy w zastosowaniu. Największą zaletą jest to, że możemy uzyskać, stosując ten materiał, prawdziwą kość.
Just looking for something. Stop. Look at synthetic bones. And one of the best.
Hello, ladies and gentlemen. Hello, ladies and gentlemen. Welcome to another free webinar that is graciously aired by CAP. And tonight's webinar is supported by Ethos. And for this, we have with us Dr. Peter Fairbairn and Dr. Stuart Kilner from the UK. And Dr. Peter Fairbairn is none other than the godfather of the ethos that you will be seeing today. And so Peter is a globally renowned implantologist and a pioneer in alloplastic bone regeneration, active in dental implantology, and he is an honorary life member and former scientific chairman of the ADI in the UK. He is a visiting professor at the University of Detroit Mercy in USA. Also, he's a past president of the London Dental Fellowship. He has a tremendous experience in implants and bone grafting, and he lectured in many, many countries. Actually, he just came back from China, where he had a very interesting tour in China. And he advocates full resorbable graft of true bone host regeneration and minimally invasive techniques. His surgical expertise covers all oral surgeries, going from implant to extraction, coronectomy, apsectomy, and you just name it. Actually, people, I was writing, if you saw me now, I was writing a report for a patient who had a papilloma, so I sent him with the papilloma specimen. And to assess, also, we're going to have Dr. Stuart Kilner. Dr. Stuart Kilner has graduated from the University of Manchester. Since then, he has developed his surgical and prosthetic skills, working in predominantly with dental implants and related restorative prosthodontics. He has undertaken 2 years postgraduate Master of Science degree in advanced implantology from the prestigious University of Barcelona in Spain. He has experienced lecturer. He is an experienced lecturer, and he lectured all over the world and many events in the UK, in Munich, Moldova, on topics of full arch implantology therapy and immediate implants. So with that, we're going to have today a very interesting session about bone regeneration, and as Peter would like to call it host bone regeneration, it would be the title of this presentation, Immediate and Delayed Loading in the Aesthetic Zone, Predictable Implant Success with Synthetic Bone Regeneration. It's a very interesting topic, and it's a very interesting subject to discuss. Peter, in my many years of experience, I have experienced, especially in the aesthetic area, when I had bone grafts done. I am a prosthodontist, I don't do surgeries, but when they do the surgery of bone graft with particle or bone in the bottles, I always experience some errant particles that starts a mucositis, and I call them the rogue particles of bone graft that creates this starting inflammation around these prostheses. I sometimes remove the prosthesis because I could not clean anything, and I don't find any reason of this irritation. When I remove the prosthesis, I see these particle bone in the sulcus. When I remove them, everything heals back. What would be the cause, and how would you treat these kind of situations?
Yeah, thanks, Nadeem. Thanks for the lovely introduction. Yes, I was just in China and I did a big lecture in Chengdu, and a young lady dentist came to me, and she had exactly the same problem on herself. And this is the problem. The problem here is this is because we're using non-resorbable graft materials, so we're never having true host bone. It's absolutely essential for the long-term success to have the graft material turn over in the pace, at the pace and the timing of new bone formation. This will give us a far better long-term outcome and will reduce these fears and these problems happening, which, believe me, happen all over the world and happen many times. I think we've essentially, I see it as gone down the wrong road for many years and just followed the path that was taken before. Putting foreign material that doesn't turn over is not regeneration in the word of English, the English language. It's augmentation. It works, but it's not the right way.
Space maintainer, I would call
Truly.
it. Yeah.
So we basically just have basically just an augmentation. It's like having a false leg rather than having a true leg.
Yeah, this is what Fuad Khouri, Fuad Khouri from Germany, Lebanese from Germany, he calls them stones. Don't use stones as bone graft.
Yeah, and we see this all the time. So it's just for us to rethink and think of what we're doing and think biologically. And this is what we're going to talk about today.
So the screen is yours. Please.
Thank you very much.
Just a reminder, ladies and gentlemen, please post your questions in the Q&A. And this session is supported again by Ethos. And we have the screen now. Let's rock and roll.
Right. Thanks a lot, Nadeem. Yes, we should have a lot of fun. And Stuart and I, we've been, both Stuart was up in Lithuania lecturing, weren't you? You had a good time?
Week and a half ago.
Yeah, and I've been all around Southeast Asia on very big lecture events from Jakarta to Manila, and then over in China with 9 lectures. And it's extraordinary how fast China is moving and how much of the future it is. And that's where all our research is coming from these days. So it's a really interesting area. Today, what we're going to talk about is this true host regeneration, host bone, because that's the important part, that we have the body growing its own bone.
Yeah, I think touching on that case that you mentioned, Nadeem, talking about that sort of popcorn particulate that we've all sort of seen come through when you're using a non-resorbable material, which sort of slowly exudates through where the socket has been. The ultimate goal in regenerative medicine and with it regenerative dentistry is using a material which is resorbed and replaced. And the ethos has a really nice function in the way in which it's how do we resolve that? In the way in which it's resolved and replaced.
Yeah, thanks. Sorry, a little poll came up that we just wanted to get rid of. There you go, it's gone. Right, yeah, so that's what we're going to talk about today. And we're going to look at it essentially in looking at just the aesthetic zone today. So yes, we're both wet-fingered dentists, and we're both wet-fingered dentists. And I started placing implants in 1990. So for my whole life, it's really been about clinical experience and then trying to understand. The most important thing is to see what we're doing and then understand why we're doing it. And this is when we look at research, and we do research. And a really interesting thing is to look at medical research as well, not just the dental research. And this is where we begin to expand our minds and expand our thinking of why things are happening. Look, we could talk for 2 days. I know I could talk for 2 days.
I lean on your wet-fingered clinical experience as well, because you've been in this practice for so long. We see so much of that long-term work coming back.
Yeah. And so we could talk for 2 days, but we've got an hour. So what we're going to look at today is implant placement in the aesthetic zone. When and why? because this is an important area, and I believe that we should retain as much of the bone. This is why even if I'm doing a delayed procedure, it's delayed immediate. And I published this in 2015 with a 600 case 10-year study where we preserve the bone and then regenerate the bone as well. And this delayed immediate was 3 to 4 weeks post extraction. We now do a lot more and a lot more different protocols and a lot more immediate protocols. Because the key to everything in healing is not the dentist, it's the body. The body is the miracle. So the less surgery we do, the better the outcome. So we're going to look at these 4 different areas. Routine protocol, which is what I published in 2015, where we have low or no primary and a temporary cantilever or a temporary denture. We're then going to look at delayed, also routine delayed immediate, where we have primary. And here we now are using customized healing abutments or big healing abutments. And this helps us prepare the soft tissue. The benefit of this is that we only have one surgery. No one likes going to the dentist, especially to have surgery. So the fewer surgeries, happier they are.
Mm-hmm.
Happy dentist, happy patient, happy dentist.
Yeah, no, I think all the protocols and all the sort of progressions in the last sort of 5-10 years have been towards minimizing the amount of surgery we have to do to get the same outcome.
And this just comes from medicine. We are not the miracle. And if the patient's happy, we're happy. Happy wife, happy life. This is the way it is. And then number 3, we're going to look at immediate and load, which is ITRT. Generally flapless for the non-acute infected site and with good primary. We can now make temporaries with either cervico or printed. We've got a printer upstairs, so we can make printed temporary crowns. The final one, we're going to look at immediate, but with flap placement. And here, there's generally a problem. And it's important that we see the problem and deal with it.
Sút đầu tiên bao giờ cũng rất nặng nề. Nó tâm lý với cả hai bên giữa thủ môn và người sút.
It's absolutely, especially in the UK where medical legal is very high. And so we're going to go through a couple of
Những
cases.
giây phút thực sự là hồi hộp, thực sự là căng thẳng.
Needs to be assessed. And the other thing is,
Trọng tài đang yêu cầu thủ môn của đội tuyển Philippines Magdalene đứng đúng vị trí.
Right, that's what we're going to look at quickly now.
Sút quá khó của Jean-Marie.
Because it's such a vast
Môn Kim Thành đã đoán đúng hướng, nhưng cú sút của đối phương là
every week there's a new paper coming out about immunology, and it's post-COVID. We've understood the absolute essential nature of the immune system.
ở góc cao, không thể cản phá. Trong loạt sút liên liều của đội tuyển u Thái Lan thì Philippines cũng thường xuyên lựa chọn những tình huống đưa bóng găm ở góc cao rất khó để cho các thủ môn có thể cản phá. Môn Kim Thành đã đoán đúng hướng, nhưng bóng vẫn bay cao hơn so với tầm với của chị khoảng 20 cm. Bây giờ sẽ là Huỳnh Như. Đội trưởng Huỳnh Như sẽ là người thực hiện lượt sút đầu tiên của đội tuyển Việt Nam.
About the way that the immune system is modulated by these materials.
Huỳnh Như đã đánh lừa được thủ thành Magdalene. 1-0.
It's essentially the more biocompatible, the better the material. Means we get a reduced inflammatory phase.
Như vậy là cũng giống như Jean-Marie của Philippines. Huỳnh Như cũng lựa chọn cách dứt điểm về phía cột bên phía tay phải theo hướng chạy đà của mình. Bây giờ sẽ là Pino Alesa.
Yeah, we're still learning a lot about dendritic cells, so we're not going to touch on that.
Có cảm giác là Kim Thành sẽ làm được điều gì đó trong quả đá phạt này của Pino. Không được. Lần này thì Pino đã đánh lừa sự phán đoán của Kim Thành.
Và lại là một tình huống đưa bóng găm vào góc cao. Thực sự điều đó cho thấy sự tự tin rất lớn trên chấm đá phạt của các cầu thủ nữ Philippines. Bây giờ sẽ là Ngọc Minh Chuyên. Đây là kỳ SEA Games đầu tiên của Ngọc Minh Chuyên. Minh Chuyên 2-2.
Như vậy là cũng giống như người đàn chị Huỳnh Như thì Minh Truyền cũng đã đánh lừa được thủ môn đối phương. Một góc sút tương tự với quả sút trước đó của Huỳnh Như. Dường như là thủ môn McDaniel đang áp dụng chiến thuật là tất cả những tình huống đều đổ về một bên để hy vọng sẽ có được một lần thành công. Bây giờ sẽ là loạt sút thứ 3 của đội tuyển nữ Philippines. Rất tiếc cho thủ môn Kim Thành. Chị đã đoán đúng hướng và đã chạm được vào bóng trong cú sút của đội trưởng Hà Ly Long. Nhưng bóng vẫn đi vào trong khung thành. Rất đáng tiếc.
Kim Thành đã bắt đầu bắt nhịp được cách sút của các cầu thủ nữ Philippines.
Đây là cầu thủ đã được vào sân ở những phút cuối thay cho Bích Thủy. Đó là Trúc Hương. Chúng ta cùng chờ xem là Trúc Hương có đáp lại niềm tin của huấn luyện viên trưởng Mai Đức Chung ở loạt sút này hay không. Rất tốt. Vẫn là một góc sút gần giống với hai đồng đội trước đó. Lần này thủ môn McDaniel đã đoán đúng hướng nhưng không thể cản được. 3-3. Sau 6 lượt sút, mỗi đội thực hiện 3 lần thì tỷ số đang là 3-3.
Và đây sẽ là sút rất quan trọng.
Người thực hiện lượt sút này là một cầu thủ phòng ngự, đó là Rasen Beat. Cầu thủ phòng ngự thì thường sẽ có năng khiếu là những tình huống phá bóng, còn không biết là tình huống này thì Rasen Beat sẽ làm gì đây. Lại chạm vào tay của thủ môn Kim Thanh, nhưng cũng giống như quả đá trước đó của đội trưởng Hà Ly Long, bóng vẫn nằm trong khung thành của thủ môn Kim Thành. Rất tiếc. Lần trước bóng đã chạm vào tay trái của Kim Thành và lần này là chạm vào tay phải.
Khả năng phán đoán của Kim Thành phải nói là cực kỳ ấn tượng. Tiếc rằng là bóng đi căng. Và bây giờ sẽ là lượt sút thứ 4 của đội tuyển nữ Việt Nam và người thực hiện đó là Hoàng Thị Loan. Hoàng Thị Loan
quá tốt. Chúng ta thấy là sự lạnh lùng của Hoàng Thị Loan trong cú dứt điểm vừa rồi. Một cú sút điểm, cú sút không căng nhưng lại ở một điểm sát với cổ dọc, ngoài tầm với của thủ thành Mark Daniel. Cực kỳ lạnh lùng. 4-4. Bây giờ sẽ là loạt sút cuối cùng trong 5 lượt sút đầu tiên. Liệu bước ngoặt sẽ đến ở loạt sút thứ 5 này hay không? Người thực hiện cú sút sẽ là một cầu thủ vào sân thay người, số 9 Maki Ariana. Chúng ta cùng cầu nguyện Kim Thanh làm gì đi. Cú sút quá khó.
To adapt immune and get better results. So we're going to just go into clinical cases because that's what we're here for. So this is a case I did about eight years ago. And as you can see, we've got a small defect in the aesthetic zone.
Quite a big defect.
Yeah. This girl's 25. All right. Now, when someone is that age, they do not deserve to live with materials for the rest of their life. They want their own bone. So you can see healing. Then it's really important degranulate the site. Can you see how clean that site is?
Thủ như đã đánh lừa được thủ môn đối phương. 5 đều. Sau 5 lượt sút đầu tiên, cả 10 lượt sút của hai đội đều đã được thực hiện thành công. Tiếp theo sẽ là những lượt sút theo thể thức knock out, một lượt một. Các cầu thủ của chúng ta thực hiện những lượt sút sau. Những áp lực là rất lớn khi mà những loạt sút trước các cầu thủ đối phương đều thành công. Bây giờ là sang Wiki. Tiền vệ trung tâm mạng số 6 sẽ là người thực hiện lượt sút thứ 6 của đội tuyển nữ Philippines. Hy vọng sẽ có sự khác biệt trong cú sút này. Như vậy là một cú sút quá tốt. Sang Wiki vừa rồi thực hiện cú sút găm vào góc cao, và ngay cả đoán đúng hướng thì sẽ không thể cản phá đối với Kim Thành.
And here it is 3 weeks later. 5 days later when we're taking the sutures out. Sorry about that.
Có thể thấy là cầu thủ nữ Philippines họ đã tập luyện sút luân lưu rất kỹ, một cú sút tung nóc lưới.
Bây giờ sẽ là Trần Thị Thu, chủ vệ và số 4. Trong những cầu thủ nhiều kinh nghiệm nhất trong đội hình của đội tuyển nữ Việt Nam tham dự SEA Games lần này, Trần Thị Thu. Cú sút của Trần Thị Thu đã bị thủ môn Mark Daniel tóm gọn ở trong tay.
Thực sự là chết lặng. Ở đoạn sút luân lưu 11m thì đúng là các cầu thủ nữ của Philippines họ bản lĩnh hơn. Nhưng chúng ta nên nhớ rằng đây là trận chung kết mà trọng tài đã giúp cho đội tuyển nữ Philippines làm nên lịch sử. Sút quá hiền của Trần Thị Thu. Sau 6 lượt sút, đội tuyển nữ Philippines đã giành chiến thắng với tỷ số chung cuộc là 6-5. Họ thực hiện thành công cả 6 lượt sút. Trần Thị Thu là người đã
anh chị lưu ý ha, anh chị ngoài cái việc anh chị nhìn vào
restorative. Implant dentistry is a restorative job with a little bit of surgery attached to it. Stuart, you were on this paper. In actual fact, this is Stuart's case, and here we've got 6 different histologists from around the world, all coming to the same conclusion that at 12 weeks we have 58% new host bone and less than 10% residual graft material. This is really important that we end up with this result, because we need to be regenerating the bone for the long-term stability of the case. Okay, that's the key. People don't understand, and it was published in 2013 by Homlang Wang, who I just lectured with in Jakarta, and we were speaking about it. It's important to look at bone quality. And how many research papers do we ever mention that word quality? Very few. Because the only way we can check quality is cause and studies. And it's important that we do look at this, because the studies generally look at an X-ray. And an X-ray with less human bone is going to be better than human bone.
An X-ray is also a Kodak moment of a specific point in time, with no guarantee for vitality of any of the bone.
Yeah, and so over the long term, the bone needs to turn over, and this is why we must not have residual particles.
I mean, one point on that: the bone is always going through a state of remodeling and turning over.
Completely,
and it's the calcium phosphate which is stepping in, and it's able to hijack that remodeling process that the bone is always going through.
So here's a paper 2016 in Korea from our friends at Hong Kong University. And if you look at that, osteoinductive conduct to biocompatible, it's now we understand immunology. We know that this is the key word. But I've underlined totally replaced by bone, because obviously these authors all put bovine bone in, and they understand that it's absolutely essential that this must be totally replaced by a bone, and in the appropriate resorption time in relation to new bone formation. So, the only material I see is beta TCP here. So, if we want augmentation, can you see the green are the bovine particles? We have 16% new bone at 6 months, 31% residual. Where we really want is regeneration, where these particles that are residual here will eventually all be resorbed, and there's a few hundred high-impact papers to state that.
Yeah.
So we look at this. This is our study here on the side, myself and Stuart's, and this is a study done in Italy where we have bovine particles. And you can see the difference where these particles are absolutely being resorbed fully here, and you can see the vascular ingrowth and the breakdown of the bodies. This is important to see because this is bone quality, something, as I said, in dentistry, we don't take seriously enough. In medicine, it's absolutely essential to have bone quality because the doctors understand that bone is living tissue and we need to keep it as such. Right, looking at covered cases, here's one again where we've got reduced primary. You can see we have a small buccal defect, and we're going to use the suture technique. I don't know. You like doing the suture technique as well?
I do. The dome device technique, initially introduced to me, certainly by Michael Ainsworth, but it's just using the PDS suture, which is a sort of slow resorbing suture placed into the bone, one side, and then bent around into the other. So there's a bit of elasticity, which allows it to sort of form this stable dome, and you can put one like that, or you can have two. We may have an example of another, but it just gives the graft a little bit more stability.
So you can graft it. So essentially, if we have a thin bone bridge, I haven't put a case in showing it, remove it, because what we can do is we need new vital bone, buccally. This is going to give us long-term success, not something that's dead and not part of the living part of bone. So it's important to do that. So here's just looking at that before. 5 years later, this is a young guy. He's bleached his teeth now a little bit. And we could run a turbine over and take that little lump there, but he doesn't mind. And it was one surgery. And again, this is what people want. By doing surgery like this with the patient's own host bone, the body develops and thickens the keratinized tissue. And it's not just keratinized tissue. What do we need? We need
bone.
And attached keratinized tissue. This is going to give us long-term success. So this is another young Moroccan guy. Oddly enough, they were both young Moroccan guys, both fighting girls, the usual trouble. And what we're going to do is we're going to place an implant. You can see we're going to angle it correctly for the angle of the jaw. And this is just going to show the suture technique. As you can see, that's the perfect angle for the shape of the maxilla. And with coaxial implants here by Southern, it allows us to place the implant and get the right screw angle. So you can see placing the suture, put it in one hole, then the other hole, hold it so you don't pull it out again. And because the suture wants to straighten, it then allows, it then locks itself into position. So here I'm just mixing a drier mix. To mix drier, mix it with as little saline as possible. And then we suture it closed. I'm just going to, for time's sake, we're going to move on, show the angle. Can you see how we maintain a screw retention angle here? And that's a 12 degree correction.
Nice sort of papilla sparing incision with a wide base.
Yeah, you always forget, keep your flaps small. Don't do big releasing flaps. These vertical incisions will go away very quickly. If not, I can show you some in 5 days. So what we need is keep the papillae. It's very important to do papilla sparing, and there's a lot of research to show that as well. So you can see making just out of composite. This was pre-printing, and we're just placing the suture, grafting. I'm using bloodstop, which just is a fabric which turns to cellulose, helps it clot.
I mean, if we just go back there, the other really nice thing as well about these cases that are sort of delayed placements is you're transposing that bit of soft tissue that was on the top onto the buccal.
Yeah, that's the whole thing, is that you effectively, whenever you do these cases, you're shifting keratinized tissue from the palate buccally So you don't need to do secondary surgeries. I've written with a paper with Stephen Chu on soft tissue surgery. I very rarely do free gingival grafting. My favorite way is healing by secondary intention.
Because you're actually growing the soft tissue that's needed there at the site, and you're just working with what the body's already done for you.
And this is a publication in Compendium looking at this technique and the model. This is the original research. So you can see this is 5 days later. Can you see the change in the biotype already? Can you see this is now at 9 weeks getting ready to load? And you can see this is doing the restoration. So can you see the change in the biotype? We're doing no free gingival surgery. We're doing no complicated surgery, which is hurting the patient. And we're getting predictable results. You're going to get predictable results if you reduce your surgery and more rely on the body.
I mean, this is a really nice re-establishment of that sort of buccal contour.
Yeah.
And you've done all this in one visit.
And you know what? It's simply working less as a carpenter and more as a doctor. So we're understanding what the body's doing, and therefore we do less surgery. And this is the key to the future as far as I can see. I don't know. You've seen this guy once, I think, at emergency. This is just a difficult case. How can we do this without doing major surgery? Yes, he wanted the staining removed, let it heal for 5 days. You can see just with a quick plastic temporary. There it is 5 days later. Yes, it was really hard getting all of this staining off the soft tissue, and I ended up tearing that thin mucosal tissue. And again, we like using degranulation burrs, and you can see really trying to. And when you look down in there was a huge cyst. So by the time I cleaned it out, I couldn't actually get primary stability.
I mean, yeah, you can see how well you've cleaned that with those degran burrs as well.
Yeah, but it's still, can you see in the soft tissue here? And I was destroying the soft tissue and I needed it to cover up. But you can see the same protocol with papilla sparing, small flaps. So I'm going to graft into that cyst, okay? And then I'm going to place this implant with no primary stability. Now, that was quite difficult because I had to get the
carrier off.
And removing the carrier, and get it out. And then we put a dry mix over. When I fitted the final crown, I had to do a bit of soft tissue because it had torn through here. So I did do a free gingival graft chair and Blue M gel I like using all the time. And that's the end result. Can you see that's where the cyst was? And we now have a stable case. So we started before here. Is this perfect? No, but we haven't done any complex dentistry. Anyone can do 5 surgeries and get the result and take blocks or do Curry plates or something. But we're trying to do this with the reduced amount of surgery, and the patient is very happy for that reduced amount of surgery. And it's been loaded 6 years now, and the predictability of being able to do these situations, it's important to get predictable.
I mean, those are the sort of cases that just get better with time as well.
Totally. We're going to talk about this because you hit the nail on the head, Stuart. When I look at, I've been placing implants in the same room for 36 years. And with these ethos kind of synthetically host regenerated bone cases, when you look at them at 12 years, they look better than they did after 1 year. So that's the good thing about being around long term. And that's the good thing about doing regeneration. Okay. Whenever people talk about regeneration and they're adding bits of animals on, that's not regeneration. They've got the English language a bit wrong. So ITRT, I know you do a lot of this now, but this is just looking at a case where we've got a root fracture, flapless. Yes, degranulate well, because there is going to be a lot of granulation tissue around this fracture point. Now you can see we've got a buccal defect. We would expect that with that fracture. And we're going to place the implant, angling how we're going to get primary stability. And this is the real value of using Southern's coaxis. I know there's a lot of angle correcting screws, angle correcting abutments now. But this just gives us that little bit of predictability. So can you see when we're going to place more into the palatal aspect and always have the jump gap. Now, this is an inverter designed by Stephen Chu. We're going to get high primary and we get from the lower portion, and we're going to have a narrow neck to get better regeneration and thicker host bone where we need it at the surface. You can see the angle correction. That looks like I'm too far buccal, isn't it? But when we look at it, you can see we've got a great jump gap and a great interproximal. Remember always to place it to the correct level. And again, yeah, this is old school. We were using Cervico. We like to print now, which works out a whole lot better. And we graft it. It's as simple as that, just grafting around. And then we fit the temporary crown fluid gel. I know that's not the ideal crown. Again, you know, sometimes there's a cost cutting, and this is the way I was doing it 3, 4, 5 years ago before printing. Here it is 5 days later. And again, because of calcium sulfate, what does your soft tissue look like? Always looks brilliant. We've known this since 1893 that the benefits of calcium sulfate is the biocompatibility leading to attraction of plasma cells, fibrinogen, and fibronectin really early. It helps this early inflammatory phase, and it gets us to a very quick healing phase. So here it is at 12 weeks later, and you can see we've kept the profile, kept the papillae, and now you can see there was no buccal plate. Now look at that lovely pink stippled tissue. We know that this is going to work well. And here we can just screw retain. There it is a year later. Yeah, I could do this case a lot better by doing a bit of style Italiano and building composites here, making this tooth wider. But wouldn't you? I know Stuart would love to get on this because that's Stuart's game, is composite bonding as well. He loves and teaches that. So yeah, you would love to get your hands on that. I'm pretty sure about that. But it's a referred case, and we cannot do any of the other dentistry. So here you see the jump gap. That's with the ethos, and this is after 1 year stable bone. You can see it maintains the profile. So this is the perfect way of getting preservation, regeneration. And that's just the scan. This is a study I did with Costa and Petros from Same Day Dental out in Dubai. And, you know, before was the buccal plate width in the blue, and after in the orange. Okay, 2011. You didn't come to this when I did this. This was a disaster surgery. Most people just did edge bonding. Here I placed that implant in front of 2,000 dentists live at a big dental show. And there it is 14 years later. And so now it's the lateral. Now I've removed this central, and oops, what have I done? You can see, yep, I ripped it. Because of that attached, the sclerosed buccal plate, it ripped the tissue.
I mean, that happens, doesn't it?
Yeah, but I'm not going to panic, because I know that if we can help the body heal the hard tissue, it'll do the soft tissue for us. It's simple like that. Remember, buccal jump gap. This is really important, okay? Implant in the right place, not too palatal, not too buccal. It's a restorative job. And there we are, making a temporary and placing one suture there just to hold it closed, blue M gel. So that's before, after. And here it is 5 days later. And you see, soft tissue, calcium sulfate, lovely result. Now, important, you can see where we're missing the bone. Obviously, the whole buccal plate came out. It's important that we graft this site. Right? And there it is now loaded at loading with the final restoration after the temporary was removed. And you can see how the tissues mature. Now, the important thing is we're going to get vertical regeneration. Can you see the new bone? So after 1 year, there is no graft material. When we take an X-ray, it's human bone. And that's what we want to see. We need to do that to look at cases. So she's got a high lip line. And as you can see, I've done no soft tissue. And there it is a year later.
That's a nice example of what we were just discussing about these cases getting better over the sort of 5 years.
And you see the papillae between the implants. These are easy to restore if you're using regenerative processes and not just putting foreign materials that give you, yes, they give you a better x-ray every day, but you want true human bone. This is your case, Stu. So just look at this one.
This is one of mine. Upper left 1 and 2 due to come out here. And just a nice photo that just shows really packing the ethos into this sort of jump gap area. So multitude of options when it comes to placing your ethos. You can either place
the other one.
Yeah, you can sort of place and then put your implant if space allows, or you can place your implant and then fill and sort of get the jump gap sort of nicely maintained. And then we've gone for an immediate temporary sort of crown here, and then 10 weeks later, something that we see when we take these off. 10 weeks is sort of relatively early. You can still see a little bit of sort of resorbing, turning over material, which dissipates and isn't present later on. But we've got a nice sort of bone level, a nice socket preserved site as well.
Yeah, a nice,
just on the
nice soft tissue, and you can see the nice papillae and the stippling, and so it's turned out, you know, a really nice case. Now the problem is if we do have an infected site, and here we can end up with problems. Can you see the pus now? And because of this root fracture. Now, whenever you have a problem like this, it's best to go and raise a flap. It's always better to see the challenges you face rather than just assume you've dealt with the problems. Always remove thin bone as well, because that can sclerose and create problems.
Thin bone on immediate threes is one point where I've sort of had small issues.
Yeah, it's always important. It's better to see that you know what you're doing. So we've done papilla sparing again, same process. Place the coaxial implant to the correct level. You can see, and at the correct angle so that the implant is in the ridge. Make a temporary. Here again, we're just using composite with Cervico. Never overgraft. All right. Another thing, when you're doing regenerative dentistry, you don't add a whole lot of stuff knowing that a whole lot's going to come out. No, it's all going to go, and it's all going to turn over to human bone. So when people say, oh, I'm losing graft, well, you're meant to lose graft as the bone grows. This is the whole idea of regeneration. So that's a dry mix. It's important to mix it with as little saline as possible so that it forms a sticky paste. Sutured closed, blue and gel. 5 days, take the sutures out. Can you see the scarring?
Mm-hmm. No.
It's already, the incision scars are already healed. Why do we take sutures out 5 days or even as little as 2 days? When we put sutures in, as you tighten it, what are you doing to the capillaries? You're strangling the capillaries. What is that doing to the host? Creating oxidative stress and a rise in ROS, which can then lead to IL-1, IL-6, and TNF-alpha, and you could end up bone loss. So you can see that's the implant graft and it loading. That's just loading. There it is loaded 12 weeks later. And when we look at the x-rays, you can see the importance of getting this true host bone regeneration. So in other words, not having residual graft material is a key to our game. In all of these cases, we've done one surgery. This is 6 years later, this central. From there, this case here, 5 years later, Stu, you've done some... Sorry.
Yes.
Yeah, you saw that. You've seen that patient done some other work. It's amazing that we just gone from here to here with no free gingival surgery, doing a preservation. We let it heal longer for 5 weeks. And this perio case, look at the condition of those gums. Look at that 2 years later. You know, it's only one surgery, no donor material, hard or soft. It's just simple. There's the case. Look at the bone before, especially on the adjacent tooth. 2 years later, we know these materials are fully resorbed. There's hundreds of paper, including ours, saying it. Now, look at that vertical regeneration and new PDL. And that is why that unhealthy state becomes this. Look at the papilla here from here.
Mm-hmm.
It's simple. We just remove the tooth. There it is there. Place the implant with a jump gap, coaxial implant, made a temporary tooth for the patient. There it is, loaded it, Blue M gel. There it is a week later. And you can see, look at the condition of the gum already. 1 week later. And here it is loaded. So that's the case before, afterwards. Again, look at that composite. I'd like you to get involved in that and take that out. Oddly enough, this lady, her daughter was missing laterals, and I did her case about 12 years ago. And she just came in, we're going to place a new crown on one of them. And it looks amazing 12 years later. And that's essentially the concept is if you have host bone only, you have long-term outcomes. And again, there was a 9 mil pocket. Look at that. 2 years later, 3 mil. Look at that blanching. That's what we like to see. There it is. Why? Important. So this is a quick case from Tina. It was down at same day in Dubai. And Costa showed me this. And I like what she did because, you know, the same day protocol is you got to have implant in the morning, temporary crown in the afternoon, final restoration a week later. And that is a tough case for Tina to have handled on that day. And that's the result 2 years later when the patient came back. You know, they flew in again. They were just doing a small correction. And if you look from before to that afterwards, it's fantastic. And all she did was remove the tooth, place the coaxial with the external hex like Costa likes, graft with ethos Buckley, and here it is 2 years later, host bone. Okay, finally, what we're going to do, I know we've kind of rushed through a bit, but it was nice to see a whole lot of different cases. And what's the key with all of this? It's about predictability, isn't it? It's about, I'm doing these cases every day, a couple every day. You need predictability, and there's nothing more predictable than the body healing its own bone. And what the ethos is doing is just maintaining space and allowing and upregulating, modulating this body ability to grow its own bone. This is always going to give you a better long-term outcome. And you know what? It does make the patients a lot happier if you say, we're going to just place something out of a bottle. It's going to help your body heal and turn into your own bone.
Yes.
So this one, now we were talking about the aesthetic zone, but look at this guy's smile. You can see his aesthetic zone extends to his lower teeth. So we decided to just put a lower one in for a bit of fun.
Yeah, so this patient came in looking for alternative options to having this lower left central incisor removed. Essentially, it developed that area because it had been kicked back through a spiraled orthoretentive wire that had pushed the apex of the tooth out. It had a bit of root treatment to try and see if they could resolve it or improve it, but he'd been told he had to have this tooth taken out. So we explored the alternative option of removing it.
Don't you see a number of ortho problems? I mean, shortening of roots. I mean, ortho is a wonderful thing, but there needs a little more care.
Yeah,
we see a lot of long-term issues from ortho.
Yeah, no, so consequence of ortho here, or ortho retention, if you like. So we've gone ahead and decided that we're going to work around his existing teeth and use the site once the tooth had come out. So we preserved the site. We came back 10 weeks later, placed one of these slightly narrow Straumann implants and grafted again over the top, and then left it another 10 weeks and then came to uncover. So it's sort of a socket preserved, delayed approach. But about 20 weeks later, we're left with this sort of healing abutment in place that's just sculpting the tissues nicely. And then through the use that healing abutment and letting the ethos and time work together, we've created this really nice profile, an emergence profile for us to come and restore
nice tight fit there, Stu.
Yeah, just about as tight as we're
Yeah,
willing to go.
it's always interesting because I was just in China and at the West China Dental Hospital, and they've got a robot there, and it's placed 200. And it was interesting to see and go through a case with them. Not sure how comfortable. How would you be about having a robot placing implant in your?
I think it's the sort of thing we'll look back in 20, 30 years time. You say, "Wow, did you really let a human do that work on you?" There might be a shifting of the tide.
Yeah, the other interesting thing is they had a navigation system, so not like X Mind or whatever. I mean, no, what's it, X Guide or something. Here they had a heads-up display made by the fighter manufacturing company at the J-20 fighter jet, and the interesting thing is you could look at the surgical site whilst you have heads up. And that's really something of the future. And I had a look at that as well. So the aspect in visiting China just to see the future was amazing. And it's interesting me discussing the future of where we really should be going in graft materials as well, and what we sort of seem to think. And for us, it seems to be, and for me especially, having done 8,000 odd grafts, it's an interesting area to see how we've progressed and worked more in this direction. Well, I'm just going to say we're probably going to leave it at that. And rather just take a lot of questions. There's a lot of questions, and I'm not actually sure how we'd ever get through 88 questions or so. But looking at it. When we look at a scan, can you see here is the initial, this is a lower tooth, and you can see the thin ridge, and then you can see at 10 weeks, that's the bone. Now, when we look at it 2 years later, do you see how much it's improved? And this is regenerative dentistry. In other words, this is encouraging the host to carry on growing bone and make the situation better in the long term. And by having only its own bone, we can sort of we can always look at it on that side. And when we look at it in the future, we know that is all that it can be, is host bone. So just looking at the chat, it is quite a lot. Anyway, we're just going to talk briefly about ADEC coming up. And we'll see you at ADEC on 1921 Jan. And also that Costa, Petros, and Anthony Ritzik are going to be doing an event on the 18th, 9 to 6 p.m. Boy, that's quite a long old day for both of them, for all three of them. And it'll be a really interesting thing, an interesting have a look at pterygoids, densification, and ethos and host bone regeneration. So we'll thank everyone. We'll try and answer some of the questions, and I'll have a quick look. That's my email address, and that's the case studies on Facebook. Let's just sort of see. Wow, there are so many. We could always answer. Anyone could probably question me later, but it is a really long
Peter,
section.
yes,
Sorry?
Thank you for this very interesting presentation. Thank you, Stuart, also for interesting.
Thank you. Let me stop the share. Let me stop the share, and we can then.
Yeah, you did.
I did stop the share. Okay.
Yeah. Okay. So it's very interesting presentation, and it's a challenging topic. Definitely, by all means, when you're removing all these, what we said, the bone graft particles that were used usually in the bone graft, and you are changing the way of thinking of this bone grafting technology. So we have a couple of questions. I usually group the questions and ask you by the topics. Let me start with the last question that we received. If the ethos is exposed what are the outcomes of the grafting? Does it dissolve in the mouse, and what is the effect of acids if it is any there is acidity in the mouse? Do you like to have ethos in confined environment, or it could be used in open environment?
Okay, again, I when I do a lecture, I often do a picture of my Porsche, and then someone else bought a Porsche exactly like mine, and they crashed it the next week. And he came to me and he said, "Damn, that car is terrible. I crashed it." So a lot of thing in life is about the experience you have, and as you know, Nadim, the older you get, the more we don't know. It's it's a sad thing. Anyway, so as to loss, it's best to have it closed. I often leave the cases open palatally or lingually and allow for healing by secondary intention. I'm not worried about losing graft material ever because I work with it every day. And so I've developed the skills and the techniques. And I've driven race Porsches, so I've developed the skills how not to crash the Porsche. And so that's what it is understanding and getting a better perception of the surgery. Keeping the surgery nice, tight, and clean is important.
Yep. It's very important because in many cases you see it's a washing. You see the product washing out, and the patients usually use their tongue in exploring the area, and this is dramatic usually when they have an open graft.
Again, the key is mix it with as little saline as possible. A lot of people overflood it. And then by taking the excess saline out with the gauze or removing the calcium sulfate, and this affects the ability or the stability of the graft material. Again, I very rarely see washout. If you do get some washout, don't worry. With socket grafting, I very rarely socket graft. Always underpack because the soft tissue has to fall in over the graft. The moment you overpack, yes, you're going to stop the soft tissue falling in and you're going to lose the graft material. So it's a technique sensitive thing.
Definitely. It's as James Bond says, it's all in the wrist.
It certainly is, as is a lot of life. Nadim, we're solving all the world's problems today, at least. And there's one here about pressure on the graft, otherwise result in bone loss. Narrow flaps. Narrow flaps are absolutely important. If you're going to raise a flap, don't worry about vertical incisions. I see people doing big things and then they cut the papillae and raise a flap not to have vertical, and that's worse, so.
Yeah, I think one of the points with this question here about the flaps, one of the nice things that we do in that sort of published protocol or the recommended protocol that we use first is the delayed approach. There's lots of soft tissue. So if we're replacing a delayed implant, but immediately loading it, that soft tissue that's been on the top is coming down onto the buccal, and our temporary is sitting on the top. So that's one really nice way that we relieve some of the pressure in the flap without doing any relieving incisions. Because most of the time I would say I rarely do a relieving incision unless I have to.
I mean, big customized temporary abutments and customized crowns have really made this procedure even work a lot better. Bone grafting, painful? No, the good thing about biocompatible materials, 95% of our patients, and we recorded over 3 years, don't take a painkiller the next day. Again, this is due to biocompatibility. There's no foreign body giant cell reaction. So we get reduced pain.
What is your experience in periodontal lesions? Have you ever used it in periodontal lesions?
Yes, and I tell you what, we are getting stunning results. And there's a whole lot of work being done at the University of Malaysia at the moment. We're using them in everything from LA4 orthognathic surgery to cleft palate cases. Now we're doing a whole case series and studies in Moldova. But perio is the interesting area because you can stabilize from grade 3 back to grade 1 in 8 weeks without splinting the tooth, even a molar. And this opens a whole lot of questions. But with these materials, we found that we can actually fuse a rabbit's spine while it's actually hopping around. So perio is a really interesting area. I have a whole section on perio and regenerating bone. And it's important, again, that you don't if you just put some bovine bone in there, yes, it'll give you a great x-ray. And yes, you'll even probe the bovine bone, but you don't want that. You want only the patient's own bone to get a true picture. So it's important.
Yeah, because the bovine will create the inflammation that will be continuous inflammation, and you don't need this continuous inflammation.
We know this sort of, we know generally the story. The thing with socket grafting, if you're going to do it, undergraft the site, cross suture a fleece on. That's all you need to do.
Do you wait until the product sets? Do you wait until the
that's another thing. Is everyone is in too much of a rush. It's always better to really look at that 3 to 5 minutes and stick to it, going closer to 5 minutes. Stretch your legs. The only complication of when you shouldn't use it is if patients are on rivaroxaban or apixaban, a DOAC, anticoagulant. This can actually lead to really consistent bleeding, and then you really will wash the graft out. I've had 1 or 2. So if you've got anticoagulants, really basically get them to stop before.
Well, definitely, it's easier to stop anticoagulants during the surgery, but it depends also from of the MD treating the medical doctor who is treating the patient and the cardiologist. And definitely, it's a big fight there.
Yeah, it's a really important thing because people with AFib, may end up having a stroke while they're off, and then you will be in big trouble. I agree, Nadeem. It's a very difficult area. Always talk to their doctor.
Just touching on the question about the granules and the socket preservation, we have a huge sort of video module online, but like you said, we're not overgrafting the material. We tend to put a collagen membrane or something just over where the fleece, sort of fleece has just been over the top, and then going with a sort of modified cross mattress suture, just to really keep it all down so it's not moving.
This cross mattress suture will work as a space maintainer, and as we know, if you just put the periosteum and you create a space between the periosteum and the bone, you'll get bone. How would it interfere with the ethos that you have in place?
No.
Have you tried a blind, double-blind test to see if you have a blood clot or if you have ethos? What will happen?
No, you see, doing double-blind, you would need ethical approval. It's a very difficult thing in dentistry, doing double-blind studies. You could only do them at a university, and it would be quite difficult to sort of treat someone not as well as the other person if you know that you're treating them not as well. That brings a huge ethics question into play. The way we're looking at it is another way to always look at these kind of cases is that even if you have a disaster or something fails, if you've done reduced surgery with materials that fully turn over to the patient's bone, you are doing them no harm in the long run. The moment we start trying to do big fancy surgery, you can have big fancy disasters happening. And also, the problem with that is if you leave material in, this could affect them for the rest of their life. So it's really important that we have surgery that doesn't damage the patient in the long term for that.
Many users of ethos talk about augmented attached gingiva. They noticed that. Do you have any concrete research? Do you have any concrete research on that can show that you have augmented attached gingiva?
Yeah, you know what? This would be a great result. I'm doing 3 papers at the moment, and I'm an old man now. I agree with you, Nadeem. I just look at it as
don't talk about age because we're at the same age.
Yeah, I know life is an experience, isn't it? It's all just a build up. But as far as the upregulation of the genotype of the soft tissue, I think it's more that we're getting thicker host bone, and therefore that's upregulating the genotype of the soft tissue. But yes, it's a pleasurable side effect to see. And yeah, that's something we do see. We see a lot, which is great, and we're grateful for. Sorry, is there indication of sinus grafting with ethos? Look, the main thing about sinus or grafting with ethos is that you're getting the patient's own bone. So what you see is what you have. If you want a good X-ray, just basically put a whole lot of xenograft in there. And if you've got no human bone, all the better. There are two different procedures, regeneration and augmentation. So I prefer to, and you must always place the implant because you're placing a material that's turning over to the patient's own bone, and therefore it'll be under the same compressive pressure, the pneumatization. So it's important that you place something to tent it up. Otherwise, it'll just push it down like it pushed the bone down before. It's common sense that. So.
If I can make a conclusion of what you have presented today, ethos will regenerate the host bone, and there would be no particles that are remaining in the site, and ethos will get better with time, and it will regenerate more, and it will let's say remodel, as Stuart has said, it will remodel much better on the long run. And you can use it it's better to use it in a closed environment. You can use it in an open environment, but make sure that the patient is not playing with his tongue or using acidic product. Take your time in letting the material set and hardens. 5 good minutes are necessary for the setting of the material. And don't over dilute the product with the saline. Use it as minimum as possible in the saline. Can you use it dry in the site?
Yeah. No. You've got to mix it with saline. Sorry.
You have to mix it with saline.
Yeah.
Saline is
This
activator.
starts...
It's an activator for this product.
Yeah.
And you could, in many cases, see a regeneration of more attached gingiva on these when you use these products. Did I cover all the topics that you have mentioned today?
You did a perfect resume, Nadim. You could have been sitting in the room here with us.
Thank you. I've been using this product for the last 7 years since I met you.
Yes, I know you're a very clever man, and I know that you pick this up straight away.
Thank you.
Thank you.
Ladies and gentlemen, I'd like to thank with that I would like to thank Dr. Peter Fairbairn and Dr. Stuart also for this very interesting presentation. Because Dr. Stuart Kirner from the UK and Dr. Peter Fairbairn also from the UK, and we'd like to thank our supporters for tonight, Ethos. And don't forget, ethos comes from ethical os, ethical bone, and this is what is been displayed today. And with that, you will receive within the coming 24 hours an email in your box. If you don't see it, please check the junk box. And in this email, you will have a possibility to see a rerun of this presentation if you, in any case, you missed any of the information that were given by our 2 speakers, and you'll get a possibility to download your certificate. If for any reason you have any questions that have not been answered, you can email us at events@capmea.com, and we'll be glad to forward these questions to Dr. Peter or Dr. Stewart. They will kindly answer you back, and we will give you the answers. With that, I would like to thank you all for this very lively evening. And I think this would be the last webinar before the Christmas and the Happy New Year. I would like to wish you a Merry Christmas for those who celebrate Christmas, and a Happy New Year for those who celebrate the New Year.
Thank you, Nadim, Katie, and everyone at CAP. Have a good evening and have a great holiday season. Thank you.
Thank you.
Bye bye. Bye bye then.